forward and back. Okay. Yeah. Good afternoon, everyone. I'm Dr. Rajasekarareddy. I'm one of the anesthetists. I'm working in Birmingham, United Kingdom. To start with, thank the organizers for giving me an opportunity. The topic which is given to me is neurological injuries and how to prevent them. I am not here, definitely, to educate anyone about neurological injuries. I'm sure all of you here are aware of neurological injuries, the incidence, and the outcome of them, whether they be temporary or whether they be permanent. Now, when we say neurological injuries, in the current setting, we have two different territories now. We've got a central neuraxial blockade, and now we have a peripheral neuraxial blockade. I don't say neuraxial, my apologies for that, peripheral blockades. Both of them are being increasingly used, and you have an increasing use of your peripheral nerve blocks now. The increase in use is, I can't say anything more, with the number of speakers who have spoken, including Dr. Raval. You have seen the increasing use of peripheral nerve blocks. Neurological injuries, they are not only a part of central neural blockade. They can happen with any type of block which you use. Wherever you use a needle to approach a nerve, that's where you get them. There is no single factor which will aim at telling that this will cause a neurological injury. It is always invariably due to multiple factors. There is more than one. Sorry, you can't hear? Can you hear me now? Yeah? Okay, sorry about that. Neurological injuries, as I said, are not a consequence of any one factor. There's always more than one factor to it. If you see in the hospital setting, we all understand most of the factors. If not all of them, we can get to most of them. Public perception is one strong thing which only understands that it's due to direct nerve injury. We speak to a patient, we tell the patients, and the first thing they ask us is it going to damage my nerves? Am I going to walk? So from the outside, it's a single factor. But in the clinical environment, there are multiple factors. If you aim at strategies to minimize the neurological complications, whether temporary or permanent, then it will work best when brought to bear on the risk factors which potentiate the risk of nerve injury. As I said, I'm very sure that all of us here know about the type of nerve injuries which can happen. Now, I will be only concentrating on the causative factors. My aim today is just to bring forward all the factors which cause nerve injury, and then the most important thing will be to work around them to actually try to see if we can minimize neurological complications. To start with, we have the equipment, and we have a lot of different equipments now. Right from start of the spinal needles for central neuraxial blockade, we now have nerve stimulators, we have ultrasound, and henceforth. Then we have the operator, who to me is the single most person who can be a lot influential in how much he can minimize or how much he can contribute to neurological injury. You have a patient who, if asleep, plays not much of a role, but if a patient is awake, does play a huge role in minimizing neurological injury. You have the perioperative setting, and then you have the environmental factors. When I say the perioperative setting, it basically includes patient selection, type of operation, outcome of the operations, post-operative care, and none the least, our surgical colleagues. Equipment factors, I've got nothing huge to tell here. We all know what we have started with the spinal needles, with the 2E needles. The basic difference is whether we're using the blunt needles or we're using pointed needles. There are a lot of studies, I'm not aiming at studies here, which say very clearly that if you use blunt needles, you will have less risk. There are studies contradicting that and say that the sharp needles don't have any further risk than the blunt needles. That was in 1970s. And then we had further studies after that which have come up and said probably the blunt needles are more safe. But the context which they have said this is the fact that where are you putting the needle? If you are putting a needle closer to a nerve where there is a movement, it is not in an unconfined space, the chances are, even if you touch the nerve, then it pushes it further away and your injury is less. So if the nerve is in a confined space, your injury is more. Probably this is the first thing we have to think, especially more so if you are thinking about using ultrasound or nerve stimulators, where we are thinking that yes, I can see the nerve, I can go near it. You're welcome to go near it, but you still have to remember that it's a two-dimensional picture, though Dr. Gopal has just given us the lecture and it's gone to three-dimensional and four-dimensional, but that yet to come. So there is scope still that you will cause neurological injury even if you're using a nerve stimulator with the appropriate current or you're using ultrasound. There are no studies to say that they're far more safer than not. But they do increase the safety from the anesthetist point of view if he is killed. Now you have the needle gauges, which I have nothing much to tell in there. You all know about them. But there is a reason I've put it there, and that people still want to use, if they're using epidural 16-gauge 2E needles, you can move on to use smaller gauges. It is a fact to think about. It does decrease the risk of PDPH. It does decrease the risk of many other complications from them, which are far more neurologically permanent. You have the catheters. We are tending to move away from epidural catheters, apart from obstetrics, I presume, because of the increased instance of peripheral nerve blocks which people are doing and moving away from epidural. But then, forced insertion of catheters can cause problems as well. And you have your peripheral nerve stimulators, which I shall come back to later. Operator factors, as I said, I think this is one of the single most important factor. Person performing the blocks, person performing central neuraxial blockades, how experienced you are, what are you doing at the time, are you training someone, are you covering more than one theater, are you covering 2 different blocks, are you manning a block area? So there's so much to that which actually dictates what is happening around you. The pressure of performance sometimes takes over, and then you give in to basically causing some sort of a neurological damage. Training, this part of it is actually very important, I feel, basically because the use of nerve stimulators and the use of ultrasound has made it very easy for people to approach these and to use these, because you can see it, you can do it. It's like saying see some, do some. But it's actually not so. It's a highly skilled job. It's easy to perform. In some occasions, you can get away with it, probably many occasions, but you'll end up sometime or the other when you're in that group where you have a pressure of performance and things like that, where definitely you'll cause more harm. And if you don't, however, follow up a system, as we have been discussing before, if you don't have a proper audit system, then you'll fall back and giving neurological injury. You won't know about it, and you'll think, oh, fine, fantastic, we're doing it, we're fine, patients are going home, nobody's coming back. Well, you won't know them unless you perform the audit and you have followed them up. Aseptic techniques, there's nothing much to say of that. I think there's a lot being told already. This is the single most thing which everyone needs to follow. There is no shortcut in providing regional analgesia, whether it is central neuraxial or peripheral nerve blocks, without appropriate precautions. And for central neuraxial, people have strayed away, and they feel with spinals they don't need to gown up. But I think if you see the legal suits and if you see the problems, for any central neuraxial block, it has to be perfect asepsis. For peripheral neuraxial blocks, it has to be the appropriate ones. Operator, the only other thing which I need to tell an operator is when we are doing the epidurals, what is the pressure we are using? It is very operator dependent, isn't it? You use air, you use saline, then you use a full syringe of saline, you use a half syringe of saline, and the pressure which you apply there, unfortunately, the breakpoint is supposed to be 11 psi. I don't know what that means. But the literature definitely says that more of us average go up to 20, and a lot of us go above that. So that itself can increase the risk of neurological injury. Procedures done awake or asleep, I shall discuss that a little bit further when I'm doing the procedures basically for how to prevent neurological injuries. Use of epinephrine in local anesthetic solutions is nothing new to you, but it does in patients who are already compromised, especially in spinal surgeries where people don't want to use it post-operatively, unknowingly people have used it, or in people who already are diabetic with peripheral neuropathies. If you use epinephrine, you can potentiate problems in such situations. Wrong drugs, wrong route. I've got nothing much to say at the moment, but we'll come to in the next slides. But they do cause significant nerve injury, permanent, when you've given the wrong drug, especially in central neuraxial blockades. Patient factors, I've already said that. If you have patients who are already compromised in terms of diabetes, peripheral neuropathies, you do have to play safe. You do have to see whether it's appropriate for you to do these or just move away and choose other methods of analgesia. Perioperative factors. Now this is one thing where we need to keep an eye on. You can do a nerve block, you can do a central neuraxial block, and you can have a surgical procedure which entails the use of a tourniquet for prolonged durations. These are the things which can cause neurological injury and compound things where then you end up post-operatively trying to debate whether it is due to the epidural or due to the tourniquet. And I had more than a couple of occasions where I would have expected my nerve block, especially the femoral block, to wear off, but my patient still can't move his knee, right? But the type of pain he has typically tells you that there shouldn't be any pain if there is a nerve block. But then it's a tourniquet, and the post-tourniquet release pain with a neurological injury is slightly different. So these are the things which we need to think about when we address these situations. Then you have positioning and compression on nerves which can compound in the presence of already an existing central neuraxial blockade or even a peripheral blockade. Now, preventive measures. From the discussion so far, we have seen that preventive measures actually center around how much we know about what are the causative factors. Knowing them in your mind will make you think that, okay, these are the things which probably I need to think about to prevent it. Probably try to move slowly to use a different size needle, different type needle. If I'm using ultrasound, it's fine. Take my time to do it. There should not be pressure. It is the association between the anesthetist and the surgeon which actually dictates how things go on between the anesthetic room to recovery. You have a calm and relaxed surgeon, 100%, your problems will be far less. If you're in the pressure to just move the list and move forward, your problems are more. This is independent of however the skill of the anesthetist can be, because there are many other factors, as I said. It can be simply transferring a patient just from the table to the bed, wherein you can give him another nerve injury. It can be as simple as that. And then you end up trying to debate where it came from, how it came from, or when it came. The most important thing otherwise is monitoring. If you have a nerve injury, pick it up early. You can probably prevent a permanent mishap happening, and probably you can restrict it to a temporary one, or you can improve recovery in a temporary one. Documentation of these injuries is also very important. Discussion with the patient in terms of precautions prior to the procedure. Do we need to do them awake? I've come across many situations in my practice in the hospital where I work in Birmingham, where we had situations where we have just given spinal anesthetics after a general anesthetic for total hips. A conventional practice, there are many places which just do them under a spinal. There are places we do a GI and then give a spinal just for post-operative pain relief. And we have ended up with neurological problems in a couple of them. You just wondered whether it is far better to do them awake, where you can elicit paresthesia, and if you elicit paresthesia, which is significant, and a patient complains, then you can actually stop doing it or reposition your needle or use a separate space. But it is worth considering whether you would want to do your procedures awake. More often than not, we are doing all the ultrasound techniques awake. We are doing the interscalines awake. People are doing block areas and doing femoral blocks and sciatic blocks awake. So you do most of your epidurals awake either. So why choose that small population of patients where you want to make things easy for yourself, or for time constraint, or if patients can't understand them properly, that you give them off to sleep and then try to do a block, and then you have problems later. Does the procedure need to be done? It is the most important thing. Do you need to do the central neuraxial blockade? When you have other alternative techniques, when you have an ultrasound available, I don't say ultrasound is all and best one, but can you think about another one? We have moved out, as already has been told even by Dr. Gopal, that I no longer do epidurals for knee replacements or hips. Then we started doing only blocks for the knee replacements, and now I'm doing only the local anesthetic infiltration, but I do a single spinal in an awake patient, and then do the local infiltration, and day 2, day 3, they go home. So there are ways around it if you want to avoid it. If it is not needed, let's not do it. If it is needed, let's continue doing it. And that's the role of the ultrasound, which we all know. I don't need to tell anything more about this. There's been a huge discussion on this. Avoiding wrong injection, this is the only other thing which I would stress on, is the fact that there are a lot of instances where the wrong material has been injected, the wrong drug has been injected. I won't even say wrong drug. There are instances where even the cleaning solution, the chlorhexidine, has been given. So the newer way of doing it probably is knowing only that these have happened, auditing the practice. A nationwide practice has repeatedly been done even in the United Kingdom. Though, do you say that we are in this century, we should not be having these, but we still have these, and we just pick them up on auditing things, going around, submitting them as articles, learning more about them. And now the National Patient Safety Agency has said that we use color-coded Luolock systems, basically, so that you know what you're doing, you see what you're doing. You label them properly. It doesn't take away the basic things away from you. It says label that syringe properly, have the minimal number of drugs on the tray which are needed. Don't have unwatered things on it. You want to use the solution to clean in a bowl, clean it, take it away, give it away, and then start. These things do minimize. At the end of the day, the neurological outcome, if it is permanent, it is somebody's legs and feet. And that costs a lot. The other problem we have is, well, this will be in different types of patients. You have geriatric patients and you have obstetric patients, where you will find that when you do a sleep blocks, especially central neuraxial, when you think you are at L4, L5, more often than not you're higher. And when you think you're at L5, higher up, you might be still higher. So the correct level is something which we need to readdress. Yes, ultrasound does give you a small option in trying to, but it is, I think, more training and more cumbersome. And probably you need to find a better way of doing things and trying to make sure just before you do that your patient is positioned appropriately, and then you do it properly. Nerve and spinal cord injury, paresthesias, when prolonged or persisting, this is the only advantage you have in minimizing injuries when you have patients awake. When you have patients asleep, you have lost this small opportunity. But if this is, I think, persisting in continuing to do it, especially in junior training hands, where there is that need to perform, that is something we need to look around and say, okay, fine, let's abandon this or redo in another space, or actually let's abandon this completely and think about something else. There is no joy and there is no alternative when you have this problem. Actually, you can't, in a legal situation, back yourself. As I said, and it has been already mentioned, I won't go into too much detail about this, but audits are a part of reappraising yourself and actually getting the message across to others. There is no shortcut to this. And yes, in the place where I used to work before I left UK, in the Fernandez Hospital, there used to be regular audits. And I think this helps a lot in basically in terms of assessing your own complication rate, as well as sending the messages across and participating in a discussion. You can see that the national audit, this is the NAP3 audit which was done in UK last year, and you can see that they have just pointed out what all possible infections and complications they had. And these basically tell you that these do happen, they happen, how much of a precautions you take. So you just need to readdress them and think. At the end, I would just say that neurological complications, though most of you know about it, the only thing I would say is it's about getting the factors, looking into them, training the juniors about the same thing, getting people to do audits, following up patients, and making sure that we don't repeat anything which we have found out that they have done some sort of harm to the patient. Thank you.